Well, hi there everybody. Welcome to Ovarian Cancer Australia's Information and Support webinar. My name is Anne-Marie and I'm one of the coordinators for Ovarian Cancer Australia's support programs. Before we begin today, I would like to acknowledge the traditional owners of the land. I pay my respects to their elders past, present and any that may be amongst us today. I would also like to acknowledge and thank the Brokaw Foundation for providing us with the funding opportunities to deliver this project. Today's webinar is on genetics and family history. You can ask questions of the presenters by typing into the chat box on the left, located at the bottom left-hand side of your screen.
Don't mind me.
Questions will be answered at the end of the speaker's presentation. Please keep in mind that our presenters cannot address individual medical cases. So if you've got any particular questions, please call the Information Support Line of Ovarian Cancer Australia, which will be on the slide at the end of the webinar. Today we're really pleased to welcome our presenters, Associate Professor Alison Trainer and Kristen Young, who's a consumer living with ovarian cancer. Associate Professor Alison Trainer is a geneticist with a specialist interest in familial cancer. She works at the Familial Cancer Centre of Peter MacCallum and the Royal Melbourne Hospitals. Alison has a particular interest in how clinical services are offered to ensure that all women have access to the benefits from genetic testing. Kristen Young has the BRCA1/2 gene mutation. Her whole family has been impacted by this discovery, and she wants to increase awareness in the community so other women and their families get a chance to choose. I'd like to begin the webinar now and hand you over to Associate Professor Alison Trainer to begin.
Good afternoon. I'm in the honoured position of doing the first web seminar from the New Victorian Cancer Comprehensive Centre here in Melbourne. And the subject I was going to discuss were the genetics of ovarian cancer and how, as a familial cancer centre, we can help families and individuals assess their risk and therefore be proactive in managing their risk in the future. So the first slide here just shows the ovaries and where they lie in association with the womb, which you can see here in the center, the two ovaries, and they're connected to the fallopian tubes. And whenever I discuss the ovarian cancers, in particular the high-grade serous ovarian cancers, you should think also that this includes any tumors that arise here in the fallopian tubes, as we know that these have a very similar origin to ovarian cancer. Now, there are different types of ovarian cancer that can occur. The majority that affect women over the age of around 30 are the cells here that line the epithelium of the ovary, and therefore they're called epithelial ovarian cancers. There are different types called germ cell tumors, which often occur at a younger age, and they have a different and in fact a much smaller genetic predisposition. Unfortunately, as we know, there is no screening at present for ovarian cancer, and if you are at an increased risk, the only way to significantly reduce that risk is to consider risk-reducing surgery. So that's removal of the ovarian tissue and the fallopian tissue, and this is usually done through keyhole surgery. But obviously it's important to try and assess the risk in order to determine whether that is or isn't the right approach to take. Once we've had a look at the actual anatomy, we can look at the pathology of the tumors. And this themselves is an important factor, as certain aspects, certain types of ovarian cancer are associated with different risks. As you can see from this graph, the large majority of ovarian cancers are these high-grade serous ovarian cancer. And we know that they can be associated with BRCA1 and BRCA2. But in addition, there are other types of cancers. The mucinous can also be associated with a different type of genetic disorder. And the high-grade endometrial, like the high-grade serous, can be associated with BRCA1 and BRCA2 mutations. It's important to know that borderline cancers, which are very early stage, non-malignant, are not associated. So it's very important when contacting a familial cancer centre or having a discussion with your treating specialist about ovarian cancer to be very clear in finding out what type of ovarian cancer it is that you have or that you know is in the family. Moving on to the next slide. The reason that we consider genetic testing is to try and identify women who may carry a fault in a gene, which may have implications not only to their own treatment, but also for assessing risks in other family members. And from all the information that has been gathered over the last around 15, 16 years since we discovered BRCA1 and 2, we know that around 14%, so 14 in 100 women who have a high-grade serous ovarian cancer will carry a fault in BRCA1 and BRCA2. Now, it used to be thought that if you did not have a significant family history, so if you didn't have multiple affected people, that the risk of carrying a fault was much lower. But in fact, some recent studies here in Australia have shown that of the women with ovarian cancer who carry a BRCA fault, around 50% of them do not have a family history. So in other words, we would now offer testing to women with a high-grade serous ovarian cancer, irrespective of whether anybody else in the family is affected. And obviously, without a family history, genetic testing is the only way to identify the fault and to work out the risk for other family members. As I said, there are other genes associated with an increased risk of ovarian cancer, and we know that the mismatch repair genes can also be found in women who develop particularly mucinous ovarian cancers. And we know that if we identify these faults, we know that other relatives and the woman herself is in an increased risk of bowel cancer and womb cancer. So that's another group of genetic syndromes which is important that we try and identify in order to assess risks. And this testing is done through the familial cancer centres. And these are found in all the states. Many states have more than one. And even if the state you're in has only one cancer centre, they do often clinics out in peripheries. So there should be one close to you. And what is a genetic test? Actually, it's a very simple blood test. The test is arranged through the familial cancer centres. It's not arranged through the GPs. It can more recently is becoming available through oncologists, and particularly in ovarian cancer. If your ovarian cancer has relapsed, we can offer testing through your treating specialist, and I'll come on to how to arrange that. And public funded testing is available for everybody who has a high risk ovarian cancer, and therefore that should be free of charge. If you have a history of the condition and therefore unfortunately were unable to test the person who has the cancer, that's not publicly funded. And in Victoria, we would charge for private testing at $800. That's really just to cover the cost of the test. Speaking to the specialists and coming to the clinic is all free. That's all publicly funded. And these prices are now dropping, so that should become more available in the future. So the questions that I'm often asked is this just research? And the answer is a categorically no. Genetic testing is now very much an important part of the clinical care of any woman who develops ovarian cancer or breast cancer with a history of ovarian cancer. And how will that help you if you already have the cancer? Well, we know that there are certain chemotherapy agents which are much more effective if we know that the cancer has arisen due to a BRCA mutation. And this group of agents is called the PARP inhibitors. These are now available. They should be on the PBS soon. They're available for women who've relapsed for ovarian cancer, and we hope that they'll become available for women at the primary diagnosis relatively soon. So by getting a test and by being found to carry a fault, it offers your treating clinician a different group of drugs to consider in how best to treat you. Will it also help your relatives? Yes. by identifying a fault in a woman who has ovarian cancer, we can then look for that same specific fault in any unaffected relatives. If they don't carry the fault, then they're not at an increased risk, and we can significantly reduce their anxiety. And if you do not carry a fault, you can't pass it on to your children. In the women who we do identify carry the fault, then we can help manage the risk and reduce the risk significantly. We know that we extend lives by identifying these faults in women who are well, so that because we can manage their risk before they develop any future cancer. At the moment, as I mentioned previously, unfortunately for ovarian cancer, screening is not possible. But there is risk-reducing surgery, and we tend to recommend that happens in your 40s. So it shouldn't in any way affect a woman's ability to have children, have a family. It does mean with this surgery that she will face a premature menopause, but we have links into menopause clinics to help decrease the symptoms associated with that. So the next question is, what should you do now? I'd recommend any woman listening to this who has ovarian cancer, speak to your specialist and ask to be referred to your family cancer clinic. We don't mind how old you are. Even if you have no family history, please ask for that referral. We are more than happy to speak to women, discuss their risk, discuss genetic testing, and if you want the test or not. It can obviously be quite confronting, especially when you're dealing with a diagnosis at the time, and you may decide that in fact this is something that you wish to consider again 2 or 3 months down the line, and that's fine. By coming to the familial cancer clinic doesn't mean that you have to have a test. It just means we can offer you more information so that you can decide whether that's something you wish to pursue. If sadly at the moment your cancer is currently relapsed, then we'd ask you to ask your specialist to phone the number there on the screen. That's 1-800-770-735. As currently we can offer testing in that setting quickly and easily with the support of the familial cancer clinic, but without actually having to come to the centre here. And that is to do with trying to access some of these chemotherapy agents that I mentioned previously. Lastly, if you have a family history, but unfortunately the close relative has died and therefore we can't test, it is worth coming to speak to us here at the Familial Cancer Clinic. We can't offer public testing at the moment, but we may in the future be able to test tissue samples, or we can offer you private testing. It's very important to realize that these mutations can come down through men as well as women. Men who carry BRCA1 or 2 mutations have a much lower cancer risk than women, and therefore we have many families where the mutation has been passed down through men, and through looking at the father's family history, we can often get some information in this regard. So don't think just because it's my father's sister who's got ovarian cancer that you shouldn't come and see us. We'd be keen to see anybody with a family history. The details of all the familial cancer clinics, how to contact them, are on the Ovarian Cancer Australian website. And if in doubt, please just give us a phone. We have genetic counsellors who are on the phone at all the time from 9 till 5 on Monday to Fridays, and they'd be more than happy to give you some information or to pass your details on to a clinic that's closer to where you live. And I hope that summarizes and answers in some of the details of questions that you had. But if you have any questions, I'm more than happy to answer them now.
Wonderful. Thank you very much. This is Anne-Marie from Ovarian Cancer Australia. I'd like to invite people who are registered for this webinar today, who are participating. If you have any questions, please take a moment to type them in. There's a chat box at the left bottom corner of your computer, and if you just type in your questions, then Alison will be able to respond to them. In the meanwhile, whilst we're waiting, oh, fantastic. got one question. Jeanette T asked, I have been offered 1,200 to send my tumour to Germany to see if I can go on a laparab. I am BRCA1 and 2 negative. Jeanette? Yep.
Hello, Jeanette. From my understanding from your question is that you've had testing on blood sample and they have not found a mutation. And we know that some women can have a mutation in the tumour, which is called somatic, so it's not picked up in the blood. There's probably about a 1 in 10, 1 in 20 chance of that. I think the question is you should be able to access such testing in Australia and discuss it with your treating oncologist. The oncologists that are currently running trials in Australia are Claire Scott at Melbourne Health and Linda Malishkin here at the Peter Mac.
Thanks for that, Alison. That's great. Jeanette responded that you got it right with what you had said about her situation. We've got a question here from Annie who's asking about clear cell type and is that genetically inherited?
I would say that the clear cell types are a much smaller group of the ovarian cancers and we don't have as much information about that group. So at the moment we would count that as having a genetic predisposition and we certainly would test you if your clear cell type was a high grade ovarian cancer. So it's more to do with the fact that we don't have information and therefore we assume that most high-grade ovarians are a risk and testing would be your best option.
Jeanette T has just responded to say that she's living in Sydney, Alison. And could you just confirm that you said Claire Scott and I think it was Linda Malishkin?
Yeah, Claire Scott and Linda Malishkin are here in Victoria. Professor Michael Freelander is at the Prince of Wales Hospital in Sydney. I would perhaps contact him and ask about recruitment to studies.
Thank you. And then there's a question from Virginia S. For the BRCA2 carriers, what age should women have their oophorectomy?
It's difficult to be too precise about this. The BRCA2 tends to be a slightly older onset than the BRCA1 and we normally recommend that women start considering having their ovaries removed in their early 40s, so between 40 and 45. We know that the risks can start earlier than that, but actually the risks are very low at that point. So it's a case of trying to weigh up the issues associated with early menopause with the cancer risks themselves, but in your early 40s.
Thank you, Alison. That's from one of our participants. Jeanette asked, is it free up in Sydney also?
From the tumour testing, I'm not sure. We, at the moment, looking at tumour testing, it's done either through a study, in which case it may be free, or if there's no study open and that you're having to source that because you're hoping to pay for the PARP inhibitor yourself, then you may have to pay for that.
Thanks, Alison. I've got another question from Sue H. Should sons of women with ovarian cancer be tested? I believe you spoke to that before.
Yes, I think, as I said, it can be passed down through to men, so that if the lady with the ovarian cancer does have a BRCA1 mutation, there's a 1 in 2 or a 50% chance that she can pass that on to her sons equally as to her daughters. The clinical significance in a man is less. He, with a BRCA2 in particular, is an increased risk of prostate cancer in his early 40s. Unfortunately, testing in unaffected individuals is not publicly funded, so there would be a cost associated with it. And the majority of men we see in this situations, it's because they are having children themselves and are concerned about any possible future risk to any daughters that they have.
Thank you. Virginia S. asks a follow-up question. Can we have hormone replacement therapy when menopause is caused by oophorectomy for BRCA2?
Yes, there's been a lot of controversy about this, and I think initially we were very conservative about hormone replacement therapy, but now it's becoming much more acceptable. There are different means of addressing different symptoms for menopause, but certainly if the first the first methods aren't successful, hormone replacement therapy at a low dose and only up to around the age of 50 doesn't seem to affect your risk, your breast cancer risk, which is really the concern with hormone replacement therapy. I would recommend that if that's something you were considering, that you contact one of the menopause clinics, and certainly here in Victoria we have one run by Professor Martha Hickey at the Royal Women's Hospital, and she would be a good person to contact and ask. It's not really the forum to discuss more personal symptoms that you may have, but there may be other issues or other forms of treatment you might wish to try first.
That's great, Alison. Thank you. Are there any further questions? Alison, there was a couple of questions sent through during the registration process. I wonder if I may bring that to your attention again, and just to ensure that we've covered it.
Yep. The questions that came through were mostly in regard to whether these mutations can be inherited from both mothers and fathers, and yes, they very much can. It's important to look into your father's family history as much as it is to your mother's. Another question asked, I have 6 sisters and a brother, and we are concerned about other siblings acquiring breast and ovarian cancer. My mother died of breast cancer. I think in that family history, I'm unsure whether the mother with breast cancer is the only affected individual, but certainly it'd be worth contacting a familial cancer clinic. We will take all the family history give us, particularly the age and the type of breast cancer. The familial aspects of breast cancer are somewhat more complex because it's more common than ovarian cancer, and therefore we assess the age at which it occurred, the type of breast cancer that it occurred, before we can come up with an assessment and decide whether genetic testing would be helpful. The next question is whether genetic testing is available to women whose mothers died of ovarian cancer. Unfortunately, at present, it's not publicly funded. We are trying to work technically to be able to try and test tumor tissue, and I think that would be a big step forward in the future because many pathology departments hold on to ovarian and many cancer tumor tissues, and if we can access this and do testing on them, that would be the most effective way forward. If not, certainly here in Victoria, we would be offering publicly funded testing to anybody in that situation who wished to pursue it, and we would currently charge $800. I'm not sure at the moment whether all states are able to offer that. And the question 6 is a woman very much asking, she is BRCA1 and 2 wild type, and was wondering what options that she had for treatment. And again, I would recommend that you contact either Claire Scott at Melbourne Health, so that's Claire with an E, Scott at mh.org.au, or Linda Malishkin at the Peter Mac, and I'll make sure that those email addresses are on the Ovarian Cancer Australia website. And even if you're not in Victoria, they may be able to put you in contact with people having studies ongoing in other states.
That's lovely, thank you. Jeanette T has posted that Professor David Bottell has access to her tumour through a study, and can that be useful to see if something can help even though she's a BRCA1 and 2 negative?
I think it would be worth contacting David and asking him that question directly.
That's great. Is there any further questions from participants? Jeanette gave you a big thank you.
All the best, Jeanette.
Lovely. Well, I think that I could thank Alison very much for that, and